Wonderful. All right, everybody. It's a pleasure for me and Mark to host now the second Expert Series program. We're really excited about it. It's very, I think, very unique. We're our dear friends and colleagues, DentalXP experts for many, many years. You're in for a real treat. We're not trying to do a symposium here. This is a sit-down discussion amongst very, very well-trained and experienced colleagues talking about concepts related to all of regenerative dentistry. But in particular today, we're going to be talking about bone augmentation, a couple of different perspectives. And our speaker lineup includes some of the best in the world, in my opinion. Dr. Khoury from South Africa and Dr. Robert Silva from Brazil. And we hope that you'll stick around for the full, I think we'll be around probably about 90 minutes. And you're in for a real treat. These speakers are outstanding. They are my dear friends. And we're going to be talking about GBR concepts. We're going to be talking about autogenous bone concepts, growth factors at the end as well is going to be talked about. And it'll be very interesting to hear what these speakers have to say, what the questions, you can submit questions online at any of the 3 Facebook groups, DentalXP World, Canadian Implant Dental Network, or Implant and Aesthetic Academy. As you all know as well, Robert Silva is a member of Implant Perio Group in Brazil. So if you want to follow Robert, I would suggest it. I was with him online just last week on Instagram doing a live program. And just take a look at Robert Silva on Implant Perio Group and Instagram, as well as the Implant and Aesthetic Academy, of course, also in his Instagram channel that Howie has. So without further ado, we're going to welcome our dear friend in Brazil, Dr. Robert Silva.
Hello, my dear friends. It's a real pleasure to me to be here with you guys. It's amazing, what technology can bring us today. In this time of problems, we have at least the chance to gather together at distant, perspectives, but, very close in the heart, and being able to share our expertise and our knowledges, with the dental community. So, what I like to do here today, my dear friends, is first, thanks the opportunity of being here together with my dear friends, and not lose the opportunity to go over a very, very hot topic, which is, bone augmentation procedures. And we know that there are different possibilities to address different cases. And I really love the way, Maurice and Mark put this together, because they use the word or, not versus. Because, we see a lot of people fighting each other, globally, because they tend to think that their strategy is better than the other. And it's not like that. We as educators, we have to, foment, the dentists, different strategies to, treat different clinical scenarios. It's like they say, different ways can lead to Rome. And, pity of that guy who has an empty toolbox. It's very nice that we have different strategies, because different scenarios can pop up in front of us, and we must be able to, to go over those clinical cases. So today I will be speaking about, guided bone regeneration, which basically means that the defect will be covered with some kind of device like a membrane. Okay. And if we do everything properly, we're going to have a good clinical outcome. So I like to say that everything here is important, from the incision to the closure and everything in between those 2 points. If you make any mistake, you're going to have a failure, because bone regeneration is not like other procedures. It's very, very sensitive procedures. So the details here are extremely important, and we must, take account of that if you want to be successful. And of course, if everything goes right, if we do everything properly, we may, after several months, we can check things like that. We can, open the areas that we did the grafting procedures, and we can see this beautiful bone formed on the previously deficient ridge with hard living bone that shall be, perforated in a good way to place our implants. So this is all it's about. And I'm so glad that all those details could be, seen in different places. I like to welcome you all as well in Brazil. If you have the possibility to come join us, we have this hands-on course in Brazil. That Maurice has been created, and it's been amazing the things that I learned from those guys. Actually, I much more learn than teach. Especially with Khoury, because he's a master, and I've been seeing him working that. It's so nice to have you guys there. So please be here as soon as you can. And those couple of millimeters, maybe 3-4 millimeters, sometimes more, really can impact the life of our patients. So obviously we have different patients with different needs, but in those cases here depicted in those three situations, we have different, three ladies with bone deficiencies. And if we do the bone augmentation procedure properly, we're gonna probably be able to, recreate a good framework for their smiles in such a way that they can bring, their life a good meaning, and they will be safe to smile and do things in a very, very good way. So when you compare, the before and after of those cases, after several years of maintenance, we can see that they're changed in a way that not only, the functional aspect, but emotional and aesthetics can be, impacted in a great deal when we do this kind of procedures. So it's very important that we have that in mind to really show the benefits of those clinical situations. So after this short, introduction, I'd like to jump to the clinical case that I'd like to show you and some of the details of that clinical case. So here I have a very, very, young lady that came from a friend of mine from Guyana, Dr. Alexandre and his wife, Erica, who were kind enough to send me those pictures and maybe work together in the resolution of that case. So here the patient is young, as I said, high smile line, and she was under, orthodontics, treatment. But unfortunately, she had an accident in the street, and she ended up losing, as you can see, 3 upper left teeth, the central, lateral, and the canine of the left side. And obviously, she's not happy about it. So after the prosthesis is removed, those fake teeth on the appliances are removed, we can pretty much see the deficiency that we can have here in such a way that not only the volume of the tissues were lost, but now because of that, she also lost, the support for the upper lip, which is also a very drastic problem for her. Of course, that we have to check her in a different perspective, in an intraorally and radiographically. And the very first moment I saw her, I could see that there was something wrong as well in the, central incisor that was there. And you see there's a fistula there in the apical area. We can already appreciate as well there's some gingival recession and maybe bone loss in the distal aspect because of the papilla loss. And the x-ray shows pretty much something going on in the apical area. Of course, that I knew already that tooth had to be extracted, and that was confirmed after we could see the CBCT of the patient. So imagine me telling her, the news that one further tooth had to be removed after her accident. She was devastated, of course, because of that, because she's very, young, as I said, attractful, pretty beautiful lady, and she has all teeth. And after this accident, end up in this very bad situation. Of course, that we had to take out the tooth. So this is what Alexandre, my colleague, did here before I started jumping into the case. So he removed the tooth in a traumatic way, minimally invasive, doing a very good curettage to remove all the granulaceous tissues. And of course that he has plated like a sponge, collagen sponge, just to help the healing tissues, the healing of the soft tissues. And this is actually where I started seeing the patient after she had, already this tooth extracted, and you can appreciate the magnitude of the problem in the anterior zone of a young lady and high smile line. So very, very challenging case for anyone to treat in a case like that. So here, there's a suggestion of the incision that I would like to do. So I would like to go to a crestal incision a little bit towards the buccal, and that's something that we can also discuss later, why to put the incision on the buccal and not on the palatal, as many of us have learned on dental schools. And of course, doing a large, incision also on the palatal area to expose well the area to be treated. And typically, in cases like that, it's almost like 100% that we have to do the vertical release incisions just to have a better access to the surgical area. So here, I have a small, X-ray before I show the video of the case, showing here the magnitude of the deficiency. And in below on our screen on the left, we can see that the printed model, pretty much showing what I was going to face in the patient's mouth. And on the right, I did like a waxing of what was my intention of growing the bone. So based on the interproximal bone peaks, I wanted that level of vertical growth. And in terms of horizontal, I basically observed the ridge of the buccolingual thickness of the adjacent teeth, and pretty much did like a bridge in that area, trying to mimic what I would like to grow in my bone augmentation procedure. So here, there's a small video, that I did on that surgery. So after the flap has been elevated, now I'm cleaning, the nasal palatal canal and cleaning all the soft tissues from the residual bone, also scraping the roots in such a way that we have a perfect, healthy environment. Here I'm doing the corticotomies to create bleeding in the area and pretty much performing the tenting screws to give a reference to the height of the interproximal bone. So here I'm starting to move to the membrane itself. So this is a titanium reinforced barrier membrane that was trimmed accordingly, and now it's being positioned in the palatal area first, and some screws are being positioned here to stabilize the membrane in the palatal area, which is very, very key if you want to be successful in this kind of procedure. And here the graft itself, I would say that most of the cases I try to take like 60% of autologous, and 40% of xenograft here in this case. So if it's possible, if not possible, at least 50% of autologous and some kind of graft material. I pretty much like the xenograft. This has been hydrated with LPRF to give some, extra, cellular and content to this area to improve the healing of the area. And this is also a very important moment where we are closing, the membrane on top of the ridge. So we should be very careful to do this in a very gentle way. And of course, using screws, you're gonna tighten and the membrane to the area in the best way possible. Here, I'm just cutting the excesses of the material, the membrane material, in such a way that the membrane is not touching the neighboring teeth, which is very important. Here you can see that I'm adding a little bit of bone to that area, which is a little bit tricky because of the shape of the area. And of course, I'm here, releasing the flap to have a tension-free closure. I always like to put like a collagen membrane on top of that membrane, but not to protect anything. Much better to cover the edges of the membrane in such a way that all the spaces are protected from an ingrowth of any soft tissue. And here a very difficult situation, which is to close this area. Here in this picture, I have the immediate post-op of the patient, and obviously that, I was able to close in a very tension-free manner, but you can also observe that there's no vestigial depth anymore, which is like almost 100% of the times happening after this kind of procedures. And as I like to say, one miracle at a time. So now it's time to do the bone grafting, and later I'll have to take care of that as obviously. So after 3 weeks, I see this beautiful image showing that the patient is healing completely well, and the final sutures are being removed. We always like to remove our sutures between 14 and 21 days, so 2 to 3 weeks. And here you can observe already that the volume was very much, recreated. And please observe that we had to cut all the fake gingiva of that, fake teeth to create the space for the rehabilitation, the provisional rehabilitation for the patient. Of course, that we have to wait. And here, in the GBR procedure, we have to wait a lot of time. Maybe it's something that we can discuss later with Khoury, the timing of waiting. And here we have to wait a lot. So generally speaking, between 9 to 12 months of healing, which is a long time. It's like a pregnancy before we can have the bone healed. And obviously, we can already appreciate here that everything is healed perfectly, and the volume seems to be very, very good, although we don't have, the keratinized tissue in this area, which is something I have to take care later on. But please observe the beauty of these x-rays. The CBCTs were taken after that time, and I was, really, really happy to see this kind of outcome. Observe that it's completely horizontal. We see a horizontal line between the interproximal bone peaks, and you can see in the lateral views that all the bone that was missing was completely recreated. And it seems by the CBCT that the quality of the bone is fantastic. So this is the moment where we are elevating, the flap after 9 months to, remove the membrane, and it's always tricky. So we have to open a large flap again, similar to the one we did to do the surgery. And it's very important to be as gentle as you can, not to hurt the soft tissues, and completely uncover the edges of our, membrane. And after I finish doing that, I already can see the whitish appearance of that membrane, which gives me a very good feeling in that area. Because if you don't have this whitish appearance, you may end up having like a very soft bone below that because of like some microbiota that has been there for some time. Now it's moment to remove the membrane. So we have to unscrew, remove all the screws, that was holding down the membrane. In a very, very gentle way, we uncover the bone. And please observe the quality of the regenerated bone. It's always, present a small layer of a non-mineralized tissue, which is not bone, of course, but that shall be protecting the bone that is below that area. You can see the volume of bone that has been created. And now we are removing the tenting screw, which is very easy to use, to do. And please observe here, I don't know if you can see here my pointer. Whenever I see this whitish area at the border of the screw head, it means that I have a very dense bone. It's like a mark of a dense bone when we remove the screw, and it's bleeding. So it's for sure a great bone to be seen. And I was, doing this probing or checking here. I could see that the bone was completely stable, like rock solid bone in that area. And you can appreciate the height and the volume of bone that I was able to create using that, technology. And here, just to make a comparison, we can see, the 3D model without the waxing, my suggestion of bone regeneration. And here you can see that I was able actually to grow more bone that, I was really intending. Of course, and obviously that we always do this over contouring of the graft in such a way that you have an extra volume, and maybe in the future we have some shrinkage. But that's a very good observation to do here in this kind of cases. Because we had an excellent spacing of those cases of that case, and because the patient was really wanting, desiring this kind of individual work, we did this kind of treatment planning, and we could see that there was a space for all of the implants, respecting at least 3 millimeters between implants and 2 millimeters between the implant and the roots. So I decided with my colleagues from Guyana to, consider, doing the 4 implants, but that doesn't mean I'm going to use all those implants in the future. So we went ahead. So after this planning, digital planning, so we used this kind of surgical guide to do the perfect perforations according to the treatment planning. And obviously, all perforations were performed accordingly in a very good way. You can appreciate that the positioning of the holes, the osteotomies, is exactly lining to the center of the surgical guide, showing the precision of that procedure. So here we can see the implants being positioned. I was amazed to see the quality of the bone during the preparation and the feeling of the hardness of the bone, during the insertion of those implants. You can see that it's bleeding, so it's quite vital bone. And after we finished performing those implants, we used it here, a 3 millimeters high healing abutments to do something that I like to do in the static areas. So here I want to protect that, newborn bone that has been regenerated. So in every single case in the anterior zone, what I like to do is to do a secondary layer of the grafting material. So here I use the tenting screws, like the 3 millimeters tall healing abutments, and to serve like a reference on an extra space for maybe some bone to be formed in between those areas. So a membrane has been put in the palatal area and positioned in the palatal area, and of course that we use some tacks there in that area to do, to hold down the membrane, and of course the small layer of the bone, and we use an endogain as well, adjacent teeth to help maybe support a new periodontal, new attachment in those areas. And the membrane was closed and tacked in the apical area to really make everything stable as much as we can see. The picture pretty much shows a beautiful image of that, reconstruction. And finally, we have to close the area again. So again, we have to do a new release and incision in the apical area. And, after the flap is released, we are ready to go, and we will be able to close that in a very, very gentle way without, any kind of pressure in the area. This is a clinical picture of the patient after 2 weeks. After, at the moment of the suture removal, everything is healing perfectly. After some time, we took this X-ray to show the very nice positioning of those implants, very well distributed in the area. And of course, that we have to wait some time to see what happens. So this is after 4 months following the implant placement. And I can see here the beautiful volume of bone that has been, recreated in this area. So maybe now after I saw this X-ray, maybe we had to place that implant a little bit towards the palatal area, but pretty much it's very well aligned to the axis of the virtual restoration that we did. So I think you're going to be fine. Everything is healing perfectly. And of course, this is the stage that the patient is right now. So next week or maybe in 2 weeks, we're gonna see this patient to start, rebuilding the soft tissues, and we're gonna create, new vestibule for her. But I like to show this upper left picture, in which shows that we have an excellent volume of tissue. And if you mark, the sizes of those teeth, pretty much you're going to see that we have the perfect volume there to recreate our, new smile of that patient. So of course that I haven't finished that case yet. So I just like to show you briefly this, these slides here, these pictures here, kind of showing what I'm about to do in that patient. So the first miracle was to recreate the bone, which I did here in this case. The second miracle was to place the implants accordingly in a three-dimensional position. And at the moment of the implant placement, I also did like a connective tissue graft to improve the thickness of the soft tissues. And after, 2 months, I did the vestibuloplasty in this area and grafting procedure to recreate the keratinized tissue. So always at least 2 surgeries at those patients, creating the bone, placing the implants and a good volume of soft tissues, and then the last touch of the procedure, which is the creation of keratinized tissue. And as you can see here, and after a lot of time, that's something we can discuss, the timing of the procedures. I was able at least to do to change the perspective of that patient, giving back not only the aesthetics for her, but also the functional aspects of the treatment. So I think I'm right on top of my, timing here. I'd like to thank everybody for joining us. I don't know how many people were there, but I hope you have enjoyed my presentation here. And of course, that this is not my work. This is the work of a group. So this is Implant Perio group. So please find some time to go to the internet and see a little bit about our work. So implantperio.com.br. In the social media, you can find us as Implant Perio as well. And I'm more than happy to be here. And hopefully my presentation has added something for you all. Thank you very much.
Robert, outstanding presentation as always. So much to think about. There are a couple of things that jumped out at me in terms of your management. Bone regeneration is not a one-step procedure. I liked your concepts related to the adjacent teeth. I also liked your utilization of the healing abutments. That's something that I think that we brought about in our article about 27 years ago. I mean, it's been a long time, but I love the way you used it. We used it with tissue, and you used it with additional bone grafting. So a secondary and even then a third and tertiary procedure, managing the soft tissue. Those are all really big parts of what we do. Everybody always just thinks about that first surgery, thinking that that's the only effort that is going to be necessary to build these very large, because what we're seeing here are large volume defects. These are not standard, typical two-dimensional defects. They're three-dimensional with a large vertical component. So flap management, manipulation, and then secondary and tertiary procedures to manage additional grafting, and then again, soft tissue management. You did a wonderful job. I can't wait for the discussion later with us after Houry's presentation. But again, thank you so much. You did great.
Thank you so much.
The next speaker is my dear friend. You'll see the screen will change for a moment, but please don't leave. The next speaker is certainly worth your time and effort to stick around. He is a fantastic colleague and a dear, dear friend. I mean, both of these gentlemen are amongst my favorite people in the world, whether they were dentists or not. The fact that they happen to be enormously talented and incredible educators, that's just icing on the cake. Howie has been a friend of mine for well over a decade. He was one of the early people involved with DentalXP and really helped build the brand of DentalXP, the family of DentalXP. He has been able to join us in Brazil for our, it's been now our 10th year. We just did our 10th year program in Brazil for the live patient surgical series in UNEMES Metropolitan University with Jose Marcio and his team, with Robert and his team, and he mentioned him, the Implant Perio group. You guys have no idea this group that they have. Again, Robert's surrounded by incredibly talented people. You know how much we love that, being Team Atlanta all these years, and I rely on David and Henry and Ronald and Marco and Marcelo, and so I understand the gravity of being able to share our work. Howie is a unique guy. He's able to do, in many ways, not only a hybrid surgeon with oral surgical, oral medicine, and periodontal training, but he seems to also have a knack for being able to learn the prosthetic side of things. He works in South Africa, as many of you know. He has his own group and his own team there in terms of his educational center, Implant Aesthetic Academy. He has a team of people that work with him, Jonathan Dutois, certainly one of them, but also Mark Baus and prosthodontists that he works with as well. Howie, we've been waiting for you and can't wait to see how you manage these very large-scale three-dimensional defects. So without further ado, Howie, let's see what you got.
Thanks, Mo, and Robert, thanks, buddy. I mean, that was just incredibly beautiful work that you showed us, and it's just I don't think anyone realizes the amount of skill, and I've been privileged to watch you at to watch you operate at DentalXP in Brazil, and there's some of the groups from both Brazil and Sarajevo. And I tell you, this is probably the best learning experience you'll ever have in your life. If you ever get the opportunity, this is the place to go, because to get the kind of tuition hands-on with people over your shoulder watching you and doing this kind of stuff and learning the kind of procedures that what Rob showed and what hopefully I'm going to show you now is something a little bit different. Really, it is one of the most amazing things, Mo. And I think what you guys have done insofar as putting DentalXP and bringing the family together, because it is a family, and it's a pleasure, it's an honor, and really cool to be part of it. It's cool that our academy is part of the DentalXP family, and it's the coolest family to be with. That's for sure. There's no bullshit and there's no ego. Sorry, I promised I wouldn't swear. Okay, but anyway. I think, Rob, what you said is that there's so many roads to Rome, and Maurice, you've said this so many times, and the key fact is, I think what I'm going to show is just something different, and I'm just going to share my philosophy, because although it might be different, it's exactly the same, because you showed categorically there are two factors. There's bone, there's soft tissue, and you have to handle both of those situations in order to try and come up with a situation. And we're showing very big three-dimensional defects, and it's just the same. No matter how big the defect is, the philosophy is exactly the same. Develop the bone, develop the soft tissue, develop the prosthetics. It's a step-by-step, as you said, as Dennis Tarnow says, one miracle at a time, and that's the key. So I'm really going to take you through just a single case and just share with you my philosophy and explain some of the things that I believe and where the science comes from what we do. And this patient was referred to me from another city in South Africa, and she had a main complaint. She had a failing bridge. This was a temporary bridge that her dentist had put in for her before referring the patient to me. She had massive apical infections around the tips of the roots, and I'm going to show you them now. And the teeth, the lateral and the central on the upper right-hand side were deemed unfavorable and not salvageable, and generally unhappy with the aesthetics. You know, the teeth were possibly the wrong sizes, and not everything was not right. So obviously we know if we look at the pre-op CBCTs, you can see pretty much on the distal, if we have a look straight away, you can see over here, there's already no bone. If you look at the tooth next door, you can see where the bone is. So really, we're starting out what things look like. If you look at the case beforehand, everything looks fairly okay. But the minute you start to look at the CBCT, you kind of realize pretty much what, Robert, what you had, a similar situation, that the amount of collapse that's going to take place in this case is absolutely crazy. Obviously, in our work, no case is complete without a digital smile design, and we start always, as Christian Coachman has taught us so well, from the face downwards. Spear, Kokich, all the greats, and the Salamas, all the greats that have kind of shown us and brought us from mouth design to facial design. And obviously, the facial flow article from the guys as well, from the Digital Smile, Carl Stanley, Coachman, etc., which shows us how we need to work face down. And that's really what we start with, because the positioning of our implants is key to fitting in with the face. It's not the other way around. So all our cases start with a digital smile design and move on from there. Once we've developed our smile design, we've worked from the face down. Now we can start. We've done a trial smile. We've already worked out where the teeth are going to be, and you can see we've fabricated a new bridge for the patient, working with what we had in the smile design. We do the extractions. We place PRF. Now, I'm personally not a person that goes and does socket grafting. I don't really believe much in socket grafting, because I want to not have anything in the area for the healing process. I don't want to put anything that I'm possibly going to scrape out at a later stage. I don't want to introduce anything into my socket that's going to possibly give me a problem. So the only thing that I put in there is PRF, and that is really also, it's anecdotal. There's not much research. In fact, Jonathan did some great research where he did published in the Journal of Period Restorative, where they did side-by-side sockets with PRF, and the histology showed really no difference. But I do find that I get better soft tissue healing, and the amounts of osteitis that I tend to get in my own anecdotal experience is less. So I do like to do it. And whether there's a placebo effect as well is also something potential. So we've now created a new bridge for the patient. The bridge is now based on the digital smile design. So it gives us the opportunity to develop the smile and for the patient to get a feel for where the teeth are going to be and whether she's going to be happy with them at that later stage. And you can see really good healing. The soft tissue is healed, and we've really just waited 2 months. And I think this is the key. If we did start doing socket preservation at this time, we would have had to lengthen the time of healing, 4 months, 6, 9 months, as Robert said, because the minute you're using synthetic materials, and I think obviously unless you're using some of the bone morphogenic protein materials, which will shorten the time, but we don't have that in South Africa, and also it becomes a very unaffordable type scenario for us to do. So we waited for soft tissue healing after 2 months, and once you've got that soft tissue healing, we know we're kind of at the perfect time now to go and start. Now, my incisions differ a little bit, and I'm going to explain why. Robert taught me the buccal, and I've actually been doing a few of the buccal, and I've actually got some good results, but I'll explain why the mid-crestal and not the palatal is the best, and it's based on Klein-Heinz's article where they put dye into the tissues, and what you could see is, if you have a look at the top here, you can see there's no blood on the top of the ridge. And when they looked histologically at the mid-crestal incision, you could actually see, if you look at the whole area here, look at that area on the mid-crest, you can see you've got very small bridges of vascularity, and that's all that you have. So you've got an area that's very devoid of blood supply. So if we make our incision in the mid-crest, what happens is we get the best perfusion, which is what gives us our supply from both sides. Now, this is the kind of thing, when we're doing soft tissue graftings, infold techniques, it's a different story. This is when we are doing bone grafting, and the basis of this article is really to get the best type of healing because of the fact that you get the best blood supply to the center. So the minute we move our incision off crest, you can see that the diffusion from one side has much further to go to get to the edge of the flap, which is where you're trying to get your most blood supply to heal. So it's just something that really this is what we base our thing on. Does it mean that any other way is wrong? It doesn't mean any way is wrong, because I think as long as you manage the tissue properly, but I think with using this technique, I think you have a little bit more leeway left and right if you don't get it absolutely perfect. And I think that's where the difference is. And, when you see somebody as skilled as Robert do the kind of work he does, I don't think, Rob, you can make the incision deep in the palate. It makes no difference where you do it, because you will get closure. You know what I mean? Because that's your skill set. And I think that's brilliant about it. So if we have a look at this case, you can see here, she had a bilateral osteotomy a while ago. So the ramus was out of the question because of these huge blocks. So we really had no choice but to go if we were going to use autogenous bone. And again, you can use so many different techniques to get to this, and I'll explain why. But you can see in the chin, we really had great bone. And one of the great things about the chin, because I always hear when I show chin grafting, people always say, yeah, but Howard, when you use chin, it's, there's the high morbidity, and really when you develop your skill set, your morbidity rate comes down. And I think, Rob, you'll agree with that, and Maurice as well. The minute you are doing these cases more and more, you're reducing your morbidity due to your technique level improving. And remember, I didn't start this last week. I've been doing this for 20 years. So, it's something that's really works in that favor. But you can see what we left with post-healing, and I'm going to go through this fairly quickly, because here you can start to see the kind of defect that we have. And this really, you can see there the vertical defect, both buccal, vertical, in all areas, what we left with. Now, the incision design for autogenous bone differs for the incision designs for any type of synthetic grafts, because the minute you move to synthetic grafts, you have to go wider, as Rob showed with his cases. And the further you take them away, the better chance you've got of not getting infections from your side. The nice thing about autogenous blocks, as taught to us by Khoury, is that you can do these incisions with direct extension. And what the direct extension incisions do is it makes your release, it makes the movement of your flap that much easier, and it's much more, you don't have the teeth in the way that tend to pull, like I'm going to show you now. So if we have a look here, and this comes down to the timing of the periosteal release, and I know Rob and I differ on this, and here I do my periosteal release right in the beginning, Rob does his right at the end. And one of the reasons, just to talk about how we do our releases, we make sure that we've got more than 1 centimeter of release. And I think this is key, Rob, and I think we'll categorically agree how we achieve it is immaterial. But the fact of the matter is you want to get that 1 centimeter over. And until you've got that 1 centimeter, I tend to not start until I've actually developed that part of it for a number of reasons. Number one, my local anesthetic is working at its best. So I've got the best hemostasis is at that point in time. I often find that when I leave my periosteal release until the end, the local anesthetic is wearing out and the patients start to feel pain. And when I feel pain, the blood pressure goes up. When the blood pressure goes up, the bleeding starts to get worse. And what I prefer to do is I like to have it so at the beginning, the bleeding starts right at the beginning. And by the time I get to the end of the procedure, I've got really good hemostasis and I get very little flow of blood under the flap because that tends to cause us a problem. If we have a look now, here's a classic case of a GBR, one tooth either side, which is the classic scenario. And one of the things that you can see immediately when you look at the releasing incisions, you start to see the tension that this one tooth either side does. And you can see how the tissue pulls up over the teeth around it. And that's what you'll see the difference is when you do the direct extension. Now, why you can do direct extensions in these cases is for the pure reason that the flap, the bone itself, the bone plates are revascularized very, very quickly. So in 3 to 4 days, Akachele in their 2010 article showed histology where the Haversian systems had blood vessels in them. So it was already revascularizing the flap so well that you didn't have the issue of flap dehiscence that you have with synthetic materials. And it also works very, very well in thin gingival morphotypes, which which is something we have to be very wary of when we're using the synthetic stuff. So here you can see the benefit of the chin, because the chin now really takes the shape of the defect, and we don't have to do all fancy things to do this. So it gives us a beautiful shape. We create the shape, we create the roof. I think if I look at this side, I could have possibly moved that plate a little bit more towards the outer side and given a little bit more bone. But one of the reasons why I choose bone, again, and I think, Rob, you said this, is the length of time I have to wait. Because in these cases, I have to wait 3 to 4 months and my bone is healed. And I think that's the key for me, is that the less time my patients, I think the patients want things first. I think if I explain to them, and if they don't want to have autogenous bone and we're going to wait the time, they are happy to wait. There's no doubt about it if you explain why you're waiting, what the reasons are. But the second thing for me is that the cost. I have a very low cost, and obviously working in a third world country, South Africa, the biologics start to become very, very expensive, and utilizing multiple bone grafts is sometimes not really a possibility. The third thing is the biology of autogenous bone is just very, very different, and obviously it still remains the gold standard in thing. But obviously there's a second site, and that is the main issue that people have. But I think when you explain to the patient the fact that you're going to have a second site, you explain why, you explain the timing, etc., etc. I very seldom have patients say, I don't want to go that road. And I really think it really rests with how you talk to your patient, because if you want to do a mesh, the patient will go for a mesh because that's what you want to do. If you want to go for a titanium reinforced membrane, that's what you're going to get the patient to go for, because you will sell what you need to sell. Here you can see we've placed autogenous bone chip all around. So the whole thing is filled up now with the gold. That's the autogenous bone chip is filled. We've put the same thing as Rob does, except we don't use any membranes, and we try and stay away. And people often ask, well, don't you put xenograft on? Don't you put a membrane on? And the answer is no, we don't, because the minute you put membranes in, the minute you put anything like that in, what's going to happen is that you start to change the healing potential of the wound. So we want to have only autogenous so that the body only has to deal with your autogenous. And if we look at what it looks like at 4 months, and I think this is always the key for me, is when I open up, there's no layer of getting on one knee. And I think that's where I was always frustrated in the old days when I used a lot of synthetics, is I'd often get frustrated sometimes at what I found. Whereas with autogenous bone, I tend to, 9 times out of 10, I'm getting what I'm if I've got closure, I'm getting what I'm expecting to get. I'm opening up and I'm finding solid, dense bone, vital, and you can see the quality of the bone. And I think that's always key for me. Osseodensification, we always osseodensify this bone. It's soft, it's tender bone, so we want to develop the bone even further with osseodensification. Sorry for the photo on the right is a little bit poor. I apologize. We were changing cameras at the time, and we got the shot wrong, and I had my loops on. I didn't look at the picture, but you can see the turning torque of these cases, massive turning torques. We always sink our implants a little bit deeper as well, because we expect once we raise the flap that we're going to lose some of the bone crestally. So we always place our implants between 2 and 3 millimeters below the crest to compensate for that resorption. And Rob, we did our lecture separately, but 100% we're on the same track, because as you mentioned, we've removed the vestibule, and now it comes down to soft tissue management at second phase. And obviously, I think I prefer to do it at the later stage. It always gives me one further bite of the cherry. It allows me to reassess, reevaluate. Is it necessary? Do I need to go, without jumping in and doing everything at once and then coming back and, okay, well, maybe I didn't need to do that. The patient's paid more, they've had more pain, etc. So the key factors here is that we've got a reduced vestibule, we've got an active frenum, we've advanced the mucogingival junction, and we really have insufficient attached gingiva. And I always find that this is where most people lose the plot. Because what happens now is they take a laser, they take a punch, they haven't thought about the soft tissue, they've really put a lot of effort into the bone, and that's great. But I think there's a group, some group in America, bone sets the tissue is the issue, but bone sets the tone. I don't know where that comes from, okay? But it's quite famous, okay? But the issue now is how do we go and expose it? Because I often sit down, this is the most important part because this is the part that the patient sees. The pink-white aesthetic, the emergence, the transition zone, this is the part now it's going to make or break the case. It's going to make the case either successful or not. Now, we're not getting papilli, so we know we've already reduced expectation in that regard. We're either going to use pink or we're going to have long contacts, etc. But we've already discussed that with the patient. We decided on long contacts. He didn't want the pink, etc., etc. So we knew where we were going. So with this technique, we did a very minimalistic type H incision, okay, to try because I either had the opportunity to do an apically repositioned flap, but because of the curvature, an apically repositioned flap would have made my flap management very difficult. So we changed to do small, minimally invasive H incisions. We placed our healing abutments into position. We sutured the little folds back underneath just to create a little bit of extra. And now the crux comes to how do we now manage the rest of it? And now we're going into exactly the same, Rob, and that's what I love. We're doing it's exactly the same sort of thing. It's just a different road, but it all comes together, it meets in the middle, and that's what's so cool about this. We do our vestibuloplasty. If we look at the publications, we don't just do vestibuloplasties. We do with the vestibuloplasties. We do a free gingival grafts. And here, what we do is we take a piece of the tissue and we cut up the piece. We get the shape right. Very old technique, nothing new. Using that piece, putting it in, taking a piece of free gingival graft from the palatal area, suturing that piece of graft into place, making sure that you've got nice, solid tissue. And the only unfortunate thing about this type of graft compared to an apically repositioned flap is this type of graft tends to shrink. It doesn't expand. And that's only negative. So it looks very cool at this stage. But the nice thing about this is that we are now at 7 months. Okay, so we're already at 7 months. We are now at this phase. And now we wait another 2 months. So 10 days later, you can see what happens. The patient comes in and it's looking nice and pink. And we always sit and pray. We hope it's going to stay that pink, but it's not going to stay that pink because it's going to heal better and it's going to look pretty much like that. But what we have is we've recreated the vestibule. The transition line is well below the lip, so we don't have a problem with transition line issues. We can really bring everything down. But what we've created is we've created good bone. We've created strong soft tissue that's going to support that bone, and we can make sure that when we move to the final, and this is the placement of the final bridge as I said, we decided on long contact. So this is where we're at with this case is at final bridge placement. And we can see now with our final placement, you can see, look, if we look over here, look where the bone's resorbed, and you can see how important it is to place your implant deep. Don't place your implant shallow in this because you are going to lose some of the vertical bone. And that was very, very important. We don't have a final CBCT. We'll get it at the next phase when we start the posterior implants. So a great result all around. We're starting with the back of her mouth now, starting to do the rest of it, and really taking the patient who when she walked in was in tears, and when she walks out, it's like it's just it's a wonderful experience to walk your patients through these long procedures through the months, because you don't just have a patient, you have a friend, you've got somebody that really there's respect, and it's both sides, because without dealing with a patient that's walked that with you, that's walked the long road that these procedures take, without having them on board for this technique, a lot of times these techniques are not really possible. So I think that's one of the key factors for any young guys or ladies that are listening, that make sure that your patient's on board for these techniques, because they require a lot of really close interaction and really a lot of cooperation from your patients. And I think that's key. And without that, you often find that's where the complications start. So we talk about positivity, we talk about complications, we talk about all the factors that are going to happen in these cases. to try and get to where we want to go. So with that, I say thank you. I think I'm just about on 2 minutes. Thank you very much. My email address, you're welcome to email me at any stage. We will always get back to you. Thank you very much to you guys for listening. I really look forward to the conversation that we're going to have. And thank everybody who's here for listening. And thank you for DentalXP and for Mark Bishara from the Canadian Implant Dental Group. Thank you so much for the invitation. It's been a real pleasure to be with you guys.
Howie, you were outstanding. You really did exactly what we asked you. Both of you guys. So many overlaps, but yet on the other hand, so many really outstanding concepts that you were in the process of displaying. And I thought it was really, really great that you could show it in the way you showed it. There were some differences, but they weren't vast differences. There were a lot of actually similarities that I thought were incredible. And I'll say, for those watching right now, as we will be moving to my screen, is that I have had the enormous pleasure of seeing both of these gentlemen in action. I've been an educator at the university level, at the graduate level, perio programs at different universities here in the United States. I have seen some of the heavyweights. I have traveled the world and lectured with some of the all-time greats. And I can tell you that having both of these gentlemen as my lead proctors, along with many, many others, greats who are probably watching, Imad Saoum, Abtin Shariari, the list goes on, as of course our all of the implant perio group who joined us the last few years. The list goes on and on and on. I'm missing many others, Marcelo Ferrer, just so many incredible educators, Bassam Rabi. The list just continues to grow, and all of them experts and friends. But when I've seen both of you work in these situations and to see how you teach, I've had the pleasure of looking over your shoulder, and I can honestly say I've learned enormously from both of you. You have both inspired me. I have gained subtleties in the way I do surgery. Howie, there's no doubt that was the lead for me starting to use this whole process of Khoury plates. Rob, with some of your flap designs and releases and the way that you secure your membranes, there's just so much to learn. And then when I see you teach it to dentists that are desiring to learn those traits, and as you all said, you've been doing it, you have vast experiences, decades of doing this, specialized education, but then to share it with your friends, your colleagues and students and the way you do it. I mean, I've seen you guys delicately share each trick live with these students and allow them to do these procedures while you're right there, many times holding their hands. And I've seen you do it even with my niece, Tony, who joined us, and I know she's watching today as well. So first, before I even get started, the enormous respect and gratitude I have for you both. I can just say that you guys are really the top, and that you're really special for me. And the fact that you were here today to show everybody your material was fantastic and outstanding. And for Mark being able to allow this to be broadcast live streaming on 3 different Facebook groups, and this has really been outstanding. So what you're seeing right here is Howie and Rob in action in these live patient programs. And, we do them at 2 different universities. I keep mentioning the universities because we get temporary licenses. This is not a private practice. This is all on the up and up. The universities, the deans, the cities know that we're there. The patients are taken care of in an ethical manner by these outstanding lead proctors and organizers and program directors, Jose Marcio in Santos in Brazil, and of course Mohamed Ajanovic, the dean of the University of Sarajevo, and his team that allow us to bring all of our students and doctors to come to these universities in a protected environment, in an ethical setting where these patients are taken care of preoperatively, postoperatively, and then long-term get restored. And I think that that's a big key for us. We've always wanted to do this in the right way. And I say the XP way, but it is the right way. And these gentlemen are my right and left hands at these courses, along with many, many others. And I, again, thank you so much for doing that with me. I'm going to share with you a case because I'd like to bring about some discussion about how we would handle something like this. This was sort of a sad situation because this woman was actually in the United States military. She was stationed in Saudi Arabia. The work was done there while she was in the military. And when she came to the United States, 2 of the 3 implants in the lower right quadrant failed. And she had a lot of infection, and I had to remove these implants. There was no keratinized tissue. And I ended up with what I would call saddle-shaped defect in the posterior region. And I ended up with a lack of autogenous, with a lack of keratinized tissue. And so this is the implants before they were removed. These are the 2 I'm looking at. There was a 3rd implant that we decided to keep because it was stable, even though it had some of a labial dehiscence. And we had to then start the process of deciding what to do once these implants have been removed. And I can tell you one of the real big issues I think all of us are having these days, and I asked both of the speakers, is this problems of now so many implants are being placed and so many people are pushing the envelope. In many cases, we're now having to remove implants and then having to reconstruct for the 2nd or 3rd time, which is really challenging, I think, for the dental community. So I certainly don't envy the future of dentistry in many ways, because if we don't educate ourselves and take on only the cases within our wheelhouse, it makes these types of situations, happen too often. And then we're faced either with our own cases or cases being referred for the 2nd or 3rd time and coming to see us to try to reconstitute what shouldn't have been lost in the first place. So lack of bone, infection, lack of keratinized tissue, cone beam CT. You see on the left screen, this is the implants that were the first implant that I said we kept in an effort to try to give her one more posterior tooth and to try to reconstruct it. The patient wanted that. But if you take a look at the defect, it is 3-dimensional. You have a very large 3-dimensional defect where the implants were removed, no labial bone, and then a saddle-shaped defect that you see that also has a vertical component as it drifts towards the lingual wall. There's also the proximity of the mandibular nerve and the metal foramen, which is only a few millimeters, if you see right here, only about 4 to 5 millimeters from where the labial plate ends. So I'd like to just throw it out for discussion, and maybe I will start. If you guys can unmute your microphones. And I'd like to start with Robert. When you take a look at a case like this is a CT scan taken 3 months after the distal 2 implants were removed, and you get a chance to see the volume of the defect in 3D, the lack of keratinized tissue, proximity to the mandibular nerve. What starts to go through your mind in terms of planning this case in sequence?
It's a very, very sad situation that you just mentioned, that we have to face that, because this is more common and common in our offices, to redo cases that people have done without probably the best, management during the execution of those procedures. But when I saw the first, picture of the case, the very first thing that came to my mind, and that it's very important to define the strategy of the treatment, is to look at the first implant, if there was peri-implantitis or not in the buccal area. So I assume that, although we didn't have the buccal bone, we didn't have any probing depth in that area in terms of,
very good
infection. Because, sometimes it happened to me already that I tried to save one of those implants, but the first one was not so bad, but there was some infection associated with the first implant too. And what I did, I removed those implants, okay, and I tried to graft. But the problem is that the infection from the first implant was, thrown at the area of the regeneration. So it's very important that we see that there's absolutely no infection in the present, the capped implant. So the second thing that I would have done if I had the opportunity to treat that case, I would have removed those implants, but at that moment, I would probably have fill the area with LPRF, as Khoury said. I really love doing that to foster the healing process, but probably I would have done at that moment as well, like a subepithelial connective tissue graft to increase the volume of that area, because we know that the number one killer of our procedures in terms of regeneration is the soft tissue management. So if you have some better soft tissue, it's going to be better for the area. So coming back after 3 months, as you said, 2 or 3 months after the procedure, in a case like that, I would probably go with my, regular GBR procedure. As you said, we have like a saddle defect, so there is a vertical component, so it's not like horizontal line from the distal aspect of the implant towards the ramus. So there might be like a concavity on that area. So that pretty much determines my choice of membrane. So I would treat that case with a GBR procedure, okay, using a titanium reinforced barrier membrane because of the saddle, kind of shaped defect. And I would, harvest the bone from the ramus area, exactly from close to the area to be treated, like 60% of autologous, 40% of xenograft, and would cover everything, and suture the flap in a tension-free manner. That's probably what I would have done in a case like that.
Robert, I like what you just said. Really, you really described it well. I wanted to take out this front implant. This patient was really opposed to me removing the only posterior tooth she had back there to chew on. So there was no perio. And you're absolutely right. If there was any type of periimplantitis, lesion, infection, pus, suppuration, I think that would have had to be a game changer, and that should have been removed. Typically, I would. What I'd like to ask you is, how about your incision design? How would you describe your incision here?
Myself, I would do like the crestal incision here. So different from the maxilla that I described, like I like to place my incision a little bit towards the buccal, because in the palatal area, we don't have the flexibility of the flap, okay? But in the lower jaw, I do the incision in the mid-crestal because we can advance the flap for both ways. For sure, I would do like, a vertical release and incision in the distal aspect, okay? In such a way that I can not only expose the, donor area, but also, make easier for the flap to be closed in that area. And sometimes in the lower jaw, in the posterior, I don't do the vertical release incision medially. Sometimes I just go, around, 2 or 3 teeth, in the mesial direction to give me the flexibility of the flap.
And Robert, do you do a small vertical on the lingual, would be in front of the canine, right?
I don't like to do the vertical releasing incision in the lingual aspect. I know that a lot of people do that, and I personally like to just go the incision intracircular, like 3 teeth mesially, because I don't like the vertical cuts, because I'm a little bit concerned about the vascularity of the flap. But a lot of people do that.
Yeah, I see a lot of people starting to teach that. I prefer to extend my incision 3, maybe even 4 teeth forward, depending on how much I want to get in terms of release. Now, on the lingual, obviously, when I first started learning, I was learning mostly a wet finger technique to do a full thickness dissection to release and make sure that I protect the the anatomy in that area. I know that you prefer to do a stretch of the fibers in the superior head of the mylohyoid muscle. So that's how you would attack this area?
For sure. Just a mark here. I have seen a lot of people during the live courses that we had here in Brazil as well, when they are starting to release the lingual flap or to manage the lingual flap. What I saw them doing many, many times is that they were kind of detaching the muscle from the bone. I saw that many, many times. And I always said, please stop it. And I make a joke with them. I say that, below the muscle, there is like a very, very aggressive snake. If you detach that, the snake gonna bite you. So in such a way that they don't do it ever again. Right. So in the posterior mandible, it's so easy most of the times to release the flap. You only have to do, as you mentioned, is to stretch the fibers. And by stretching the fibers in a blunt way, we have a tremendous, release of the muscle and the lingual flap in such a way that it's able to cover any kind of graft you want in the posterior area. The tricky part,
just as a review, you would do this as a GBR technique.
Yep.
Titanium reinforced PTFE, right?
Yep.
Deep PTFE membrane, so a non-resorbable membrane.
Non-resorbable.
Would you use any tenting screws?
When I use, when I do the vertical defects, that is a vertical component, of course, and I'm using the titanium reinforced barrier membranes, I always like to use the tenting screws just to help me to support the membrane, to fold the membrane into from the lingual to the buccal area. It's not really to support the membrane because the membrane itself, it's self-supportable, okay? But, just to give me the reference to the height of the regeneration, and when I'm closing the membrane, it helps me to not make the bone go in the apical direction. Okay?
Mm-hmm. And you said you would harvest some bone from the ramus and mix 60-40 with a synthetic bone.
Yeah, xenograft or something like that. And of course, that in all my cases, if I'm able, I'm going to mix PRF with to the mixture, just to create some more, easiness to adapt the bone graft to the area because of the sticky bone style material. It's so much easier to place the bone graft in the area, and it helps a lot in the soft tissues. It really fosters the healing of the soft tissues, as how we mentioned in that area.
Very good. That was excellent. Howie, give me a kind of a run through how you see this case in your hands.
I think I would have maybe a slightly different angle to it. Is the first thing is I wouldn't accept the patient's thing of that implant in front. If I'm going to do a bone graft there, I'm not doing it with that implant in front. I think the fact that there's no suppuration at that point doesn't mean it's not going to come back and bite you in the ass. And I've been bitten, and I think from that point of view, I would be pretty much not a no-go in that regard. But I think that being said, I think these days I'm far less likely to do massive augmentation in the posterior mandible than I used to be in the old days because of since the inception of short implants. And what I would do in this case is I'd probably leave it for a good 4 months to heal completely. So I wouldn't leave it at this point in time. There's still a lot of maturation and kind of settling of the bone that's going to take place, because that would give me the option of the utilization of short implants as an option for myself, because I know I can always come back and graft the case. And I think Craig Mish gave at the last DentalXP meeting, he gave a beautiful thing about short implants, or I can't remember if it was the last one or the one before, about the use of short implants. So I think I would always give that as an option. I would always look at that as an option and leave that option open to reduce treatment time, to reduce the need for massive augmentations, and give stuff. I mean, I've got lots of cases running around now with, I put, 3 3 short implants all splintered, and 5 years later they're looking fantastic. You know what I mean? They really, really are looking fantastic. So that's always an option for me. So I would leave that option open by letting it heal a little bit longer. If it was a situation where I didn't have the space and I needed to graft, I had no choice, or the patient, you know, we obviously discussed the pros and cons of short implants versus long implants. So there's a whole dialogue, and that's what I said at the beginning, whereby we're getting the patient on board. We are bringing the patient onto our side of the court. So we're playing a game of doubles. You know what I mean? We're playing together. We're a team. And once the patient's on board and they understand short implants not bad, we have to do the grafting. I think for me always, titanium reinforced is always an option. But I think, again, for me, the key here would be an autogenous block. It's just my go-to, and where I'm more comfortable. We've got space right behind it where we can probably harvest a very, very nice piece of bone. So it's a single incision that would go a little bit further back towards the ramus, and you'd be able to take a piece from the ascending ramus coming down. And then really what I would do with my first block is I put my first block as the roof and then pack my bone in the buccal, and then that would then create I would set my vertical first, using that block, and obviously the mesial portion would be the mesial bone height would then be my limiting factor as to how high I could go. Funny enough, distal you can sometimes leave it sitting in midair, but mesial you need to have one wall at least that's going to give you. But you've got nice lingual walls, so I think the lingual wall as well will give you great support for your graft. And then once I've got that packed with autogenous bone, I put a buccal plate over the buccal, PRF over the top, and closure exactly the same as the way Robert says. I would not make vertical incisions at all on the lingual side. Never. Don't do it. Very gentle stripping and stretching of the mylohyoid muscle to get most of our release. Buccal releases right up until very, kind of sneak up on the nerve with a very superficial cut in the mesial, rather extending further forward to get the release on the mesial, and periosteal releases on the distal to give me the primary closure that I need in this case. But I think that's pretty much the way I would manage this case and handle it.
Howie, if I told you, there's a couple of questions, but if I told you that the distance that I'm showing you with this arrow on my from the metal foramen to the height of bone here is about 4 millimeters. What is the height that you would start saying, you know what, a short implant's not going to work for me? Do you have like a number in your mind that you say it's 5, it's 6, it's 4? What's too short?
I don't have a number in mind. I have a patient in mind. And I think that's the key factor. You know what I mean? It's not about the numbers. It's about what the patient's needs are and what they require and what they're able to go through and manage. There's certainly there's the micro smalls. You've got the smalls, the ultra smalls. I don't know what the real classification is, but you've got the 4 millimeter implants which you can place in a position like this. And I think once you've got healing here, you'll probably get another millimeter or so. So 4 millimeters, if I can put multiple implants, if I can put, say, 3 or 4 implants in there, more implants is key. I have to put many more implants in. So again, it comes down, can the patient afford the multiple implants that I'm going to be placed, or can they only afford the one? If it's just the one, okay, well, then the bone graft is the better option, and then I can put a single implant if it's just for a single site or 2 implants. So it really, there's a lot of options, and a 4 millimeter I've used successfully many times. 6 obviously is better, but 4 works. I've had great success with them. So as I say, I lean more towards that because it's more atraumatic for the patient. But again, it comes down to patient selection and what the patient's needs are more than what the anatomical needs are. Because I know that whatever the anatomical needs are, there's something that I have that's going to allow me to get to that position, whether I use autogenous.
You made good points there. Absolutely. I'd like to ask 2 questions to both of you, and then I'm going to show the case. Number one, does age of the patient matter when you make a decision, age and health? And number two, in terms of short implants. And number two, or going with a bone graft. And number two, would you ever consider, and we've seen this in the literature, and there's a group of people who have done some research and publications on placing implants above the bone defect and then grafting over the exposed portion of the implants. You've seen people like Massimo Simeon in the past and Carlo Tinti who've shown placing implants into the defect, whatever remaining bone you have, but then placing a certain height of the implant it's out of bone. So the two questions: age, how do you consider age of the patient, health? And then would you ever consider leaving a portion of your implant outside of the bony defect and graft around it? Robert, why don't you start?
Okay, I consider much more, regarding the first question, I consider much more the health of the patient as opposed to the age, of course, but if the patient is older, I would much more consider something more conservative, just as Khoury just mentioned. But most of the times, for me, the health is much more important than the age of the patient. And I always tell them, of course, the options that they have to be treated. But for sure, health is key to determine the direction of the treatment. And I did sometimes, more towards the past, some cases, placing the implants as a tenting poles, okay, using them as the vertical, support for the membrane. But I think it's much more, dangerous to do like that, to do like staged. I prefer, because I have the opportunity to wait for the healing of the bone. And if something goes wrong, like an exposure of the membrane, that can always happen, I may not put the implant into jeopardy as well. So I prefer much better doing like stage as opposed to simultaneous reconstruction in these kind of cases. But I know a lot of people that they like to do it. I only think it's much more dangerous in the perspective of the overall treatment of those cases.
Khoury?
I think I've got nothing to add with regards to the health. I think I agree with Rob 100%. With regards the other question, the answer is absolutely not. I think in my hands, and I don't. Again, it comes down to that one thing, one miracle at a time. And I think you'll definitely see cases where it works really, really well. But I think when you do those kind of cases, you'll also see a lot of cases that work really, really badly. And I think that comes down to the two words that I use most in all my lectures is predictability and reproducibility. And there's no doubt that it can be done. It's been shown, it's been published. Some beautiful cases. It certainly requires a huge amount of skill set. There's no doubt about that. It's not something for the faint-hearted, and it's not something for the beginner. It's something that requires perfect soft tissue management. It's something that requires perfect bone management. It requires all your stars have to be aligned. And I think that's the only reason why I say no. Would I do it? I agree with Rob 100%. One miracle at a time. Does that mean it can't be done? Of course it can be done. It's been done many times, and we can see some really beautiful results. And you're probably going to show us what you did here.
How first of all, I'm going to tell you guys, for all the people watching out there in the world right now, we did not discuss this presentation. I did not see your presentations. You did not see each other's, and you did not see mine. So we came on this the way it's supposed to be, friends discussing concepts and ideas. I am in total agreement with everything you both said on that issue. I am not a fan of using implants in zero wall deficiencies as tent poles. I think it's a risk not worth taking, even though there are certainly people who are very talented who have shown it and that it can work. I don't think it's worth taking the risk. what Howie, what you mentioned, and talking about short implants, for sure, what Craig Mish has said, Robert, I'll get to you in a second. What Craig Mish has said about the utilization, what he calls as a graft-less procedure, not less grafting, but graft-less, placing shorter implants in these patients who have a brittle health and older patients, and it depends on what they're trying to achieve, have to be considered, because then it's less morbidity, less pain, less risk. Robert?
Yeah, just not to mention as well that when you do cases like that simultaneously, in the perspective of positioning those implants, is much more difficult and challenging to place those implants, without the bone there to support us. So I would say that's much more advanced. A lot of people think that it's more advanced to do what Howie did and what I've shown. But I would say that doing that, everything on the same time, is much more advanced and may lead to much more problems as well. So I completely agree with Howie and you on that regards.
This is a question.
Before I show what I did in this case, I want to first preface it by saying this case I treated was about 2012. So just to put in perspective, a lot of the things I'm doing now may have been different. Maybe shorter implants would have been considered. This patient was in her 40s, so age, she was healthy, she was ex-military. She was, one of the things that Howie mentioned, the psychology of the patient. Is the patient willing to go through multiple procedures, the swelling, the trauma, the morbidity of the case? So we almost have to become not only medical doctors to assess their health, but psychologists to assess their mind, in their strength of mind, to go through numerous procedures to get to the outcome that we all want for them and what they want. So I think that that's an additional concern. I will also say what both of you showed was absolutely at the top of regenerative dentistry. It is miraculous. It's wonderful to know that with proper training, with proper schooling, with understanding of biology, with the ability to manage multiple procedures in hard and soft tissue, only through that can you manage these large three-dimensional defects. So I'm just going to start by saying that it's not for the faint of heart. It's not for the person who's just starting out in regenerative therapy. The cases that you both showed are for really people who have been out there doing it for a while, and for people who have a lot of experience and have taken a lot of training. Having said that, I'm going to obviously share with you an alternative. I think that Robert showed beautiful GBR procedures that were outstanding. I think Howie showed beautiful autogenous plate procedures with incredible skills for both of them on the secondary and tertiary procedures with soft tissue. I will start by saying I have a list of common denominators. So to summarize, if you wish, I'm going to try to summarize my concept in my mind. I always look at where's the space going to come from? How am I going to maintain it? Where's my access to regenerative cells? Will I and should I utilize growth factors, and will they be autologous or will they be recombinant? How will I stabilize my bone graft? Where is the access points for me to stabilize it? Will I use a membrane, and what type of membrane will I utilize? And of course, how will I do my flap to attain tension-free closure? I think these are common denominators that constantly go through my head in this fashion for me to then come up with a concept for treatment. This is what the area looked like at the day of removal, Robert, is exactly what I did. What you suggested is I placed a autogenous connective tissue graft in the areas of the missing tissue due to the loss of the implants. So when the implants were removed, I simply debrided the areas, and then rather than just allow it to heal without any keratinized tissue, I added keratinized tissue. And I'm still lacking, but I do realize I have more thickness than I had originally. So what I attempted to do, and you'll see that front implant, Howie, this is the one she wanted to keep, and you can see the threads are exposed on the buccal. The bicuspid, first bicuspid implant was stable, and the defect starts right about here on the labial, down several threads on the buccal, so below where this is. So detoxify this implant surface, we're going to use titanium brushes, we're going to use tetracycline, and then we're going to use a low-level laser treatment to detoxify the implant surface, as has been mentioned by George Romanos. I've been doing that for years. We're going to then go ahead and try to harvest autogenous bone. And we're going to do that from the area that you both had mentioned, whether it's block or particulate. You have a lot of space in the distal part of the flap to extend it and to gain a large amount of autogenous bone. So if I'm going to be doing a three-dimensional defect with vertical component, I'm always going to add autogenous bone. Now, when I take these ACM drills, auto chip makers, what I like to do is not only harvest the cancellous bone, I also like to harvest cortical bone and mix it with growth factors. Here, mixing it with the PRGF, plasma-rich growth factors. And I go back and I then try to harvest on the outer wall, the ramus, to get some more dense cortical chips. So I have basically making up my own cortical cancellous 50-50 mixture, but of autogenous bone and mixed with the growth factors that we harvest from the patient's blood. So we can harvest quite a bit of bone here, either in block form to use as plates today. That's probably what I do. I've moved away from using blocks, and then mixing into sticky bone, which Robert talked about, making sure that the bone is stabilized and stays in place. The second thing is, and you can see the area here where I harvested the bone in distal, I'm going to then go ahead and place tenting screws, and I'm going to place the tenting screws three-dimensionally to support my membrane, in this case, whatever membrane that's going to be, three-dimensionally to assist in that support. So here on the left screen, you see my intramarrow penetrations to get some cells and bleeding from the cancellous bone. You see the small area here of dehiscence on the first implant. You see the high ridge and saddle-shaped defect. So you do have a high point of bone on the lingual aspect, which is very helpful. Here's the first tenting screw. And then I place the second tenting screw, and you get more of an idea here. So we extend the flap a great distance. We don't do a vertical. We extend it all the way up here on the lingual. And then we extend it also on the labial all the way to the incisors. So at least 2 teeth extended on both sides, 2 tenting screws, and the harvest site of the autogenous bone. Now the big thing for me is, what are we going to use as a membrane? And, you know, we're going to go through membrane selection quite often with a lot of different concepts. And thank God there's a lot of new technology. Robert recently introduced Howie and I to the company in Brazil called Plenum, who's developed a very, very unique and outstanding new membrane that's not yet available in the United States. But I think it's an outstanding concept. When I did this case back in 2012, Zimmer had come out with a Achilles bovine collagen membrane. And they said it had structure. It felt like cardboard. And I'm just letting you know what happens sometimes when we're the first to try new materials. When I put this material in, it was very rigid. And I thought maybe I would use a new style collagen resorbable barrier. But as soon as it got saturated with blood, I started to see sag. And so as soon as I saw any type of deformation of shape, I decided not to use it. And that's another thing. When you're starting to use new materials, you need to be able to evaluate it. And if it's not working for what you need to be able to comfortably not use it and move to a more stiff material. At the same time, recombinant BMP2 was becoming, it was very new to the field. It was the first year that it was introduced, or second year, I think. And we wanted to have a robust healing of this three-dimensional defect, so we decided to utilize an extra small BMP to mix it with the collagen sponges, which is what you're seeing here, saturated in the collagen sponges. And we mix those collagen sponges with the bone that we harvested from the ACM drill. So it's all autogenous. For three-dimensional defects, I use all autogenous when I mix it with a growth factor. If I'm going to be doing something that's more of a horizontal defect, I don't mind mixing a 50-50 with a alternative graft material. Typically for me, it's going to be a 50-50 cortical cancellous mineralized irradiated bone that I typically use. And then I pack it around the tenting screws. So now I have my bone graft, my growth factor, and I have my tenting screws. And my membrane now has to be something that's going to be rigid enough to maintain the space. Robert had mentioned a titanium reinforced DPTFE membrane, which certainly could work here. I decided to utilize a titanium mesh. And there's a lot of different types of meshes out there and a lot of different types of screw fixation systems. This is a real clever system that I was introduced to over a decade ago, Neobiotech in Korea. This screw that you see here is the tenting screw. Here's the intramural penetration. It's another case. And then a titanium mesh and the screw that actually fits and stabilizes the membrane into the tenting screw. So you have a screw held in by a smaller screw. And it was a very interesting concept, and I decided to use it here in this case. I use larger vents on the mesh, so I'm using an 030 mesh. This is from Salvin Dental, and I'm using the tenting screws and the fixation of the tenting screws with the Neobiotech GBR kit. The flap here, this was before my days of stretching the superior head of the mylohyoid. I did this with a full release with a wet finger approach. And on the labial, as Howie mentioned, extending my flap mesially and then staying above the mental foramen and dissecting outward towards the lip in a horizontal or oblique direction. So now what I have is a mesh that's secured to the tenting screws on the labial. And I also put two smaller screws to fixate the membrane on the lingual. So this becomes a very large graft, so you have to make sure that you get release on both the lingual aspect and the buccal. Much like Robert, you mentioned earlier today that you like to place a collagen membrane over the mesh. Here I use pericardium. It's a very nice material. It's drapable and it adds thickness to the flap. And then of course I use a PTFE sutures here to first do my horizontal mattress, as you see here, to invert the wound, and then I run a running mattress in the same material. I typically use in the posterior a 040, 050, in the anterior 50 or 60. This is day 0, and to get an appreciation of the amount of angiogenesis and swelling that takes place, regardless of any of the procedures, whether you did it with GBR straight, whether you did it with plates, blocks, or BMP, you're going to get swelling in this area. But what I have seen in my cases is that when you use BMP2, your swelling is enormous. It has to be discussed with the patient, and it can last for anywhere from 1 to 2 weeks. What you're seeing here is already at 2 weeks healing. And to get an appreciation, the surgery was done on the right side. And you can see at 2 weeks, although the bruising is gone, you still have some swelling of the face in this area. So what's really nice about the sutures, obviously, for me, is their stretch. I don't see the tearing at the flap margin, which is obviously what we want. So this gives you a little bit more of an idea. Maybe the representation in the CT doesn't always give you the exact idea. But we wrapped the mesh along the facial. So I grafted the facial of the exposed threads of this implant that we retained. And then we extended the mesh all the way back. So this is the defect that you're seeing. So three-dimensionally, we're rebuilding an entire ridge. Now, the reason I mention that, Howie, is that if we take a look at where the mandibular nerve is in the mental foramen, the amount of bone we have here, although suitable for shorter implants, would have left us pretty far with a very long, obviously, crown-to-implant ratio, which, of course, Craig has shown is not really an issue because implants are not teeth. But it would have been a significant step down in terms of hygiene and cleanliness. And I sometimes also think about that as well. So radiographic review. Typically, another question that's going to be coming up soon is timing of healing with these procedures. With blocks and autogenous plates, I'm typically waiting 4 months. But with GBR, as Robert mentioned, we're typically waiting 6 to 8 months. And with BMP2, I'm typically waiting 8 to 10 months. So time becomes an issue as well in these procedures. But what's nice to see here is that at 6 months, we have no mesh exposure. The incision has remained. Now, when we take a look at the pre-op and then we look at the 6-month CT scan and we start to look at the quality of the bone here where the mandibular nerve is drawn out, and I take a look, you can see that the levels of the density readings that we get with these types of grafts when you wait long enough, especially with autogenous bone, is we get very high Hounsfield readings. So here we have 456. Some of the readings were as much as 6 to 7 to 800. Here's a cut of this section, which really shows you space maintenance. Here's the membrane, the titanium mesh, and we drape it onto the lingual. We bring it all the way down here. Here's the tenting screw. So all this bone from here, here's the nerve, from here to here is all new bone. And when I take a look at the quality of this bone in terms of density, we have 769. So it's rock solid. And when we look at it three-dimensionally and you can highlight the colors, space maintenance becomes obviously clear. The membrane is now colored in pink. You can see it clearly, three-dimensionally rebuilding the ridge. And here you can see, so one of the problems I have sometimes we'll talk about during the Q&A is that when I'm using plates, if you're going to use a plate on top, usually it's a more right angle regeneration. It's not doesn't look more like a ridge. It'll come up straight and come up straight. So that's something with a person like Khoury has so much experience is not going to have as much of an issue. I sometimes have an issue with where I place that right angle as opposed to the curvature of a membrane or a mesh that I can shape. Now the issue of uncovering. When we uncover the mesh, and another question is going to come up in terms of how these things heal, is when you look at GBR cases, any GBR case, and you remove the GBR, underneath the GBR, you typically see this shiny material that may be soft for a 0.5 millimeter, maybe, could be less. But that shiny material is usually a pseudo periosteum, and I don't remove it. So when you take these membranes out or meshes out, very important that you take it out slowly and dissect it out to leave behind that pseudoperiosteum. So what you're seeing here is the mesh, and here's the tenting screws. You have complete three-dimensional form. We take out the fixation screws from the tenting screws, and you can see that one of the tacks on the lingual. And this is the three-dimensional form. This is tenting screw in the area of the second bi, first molar, and second molar areas. Tenting screws removed. Then as I start to peel away with a blunt instrument, slowly peel this away, what you're seeing underneath is a stamped regenerated ridge, meaning that the only thing that you see here is the absolute shape of what was left behind it, which to me is a proof of principle of the whole concept of GBR and growth factors. You grew everything below the mesh that was intended, all the way up to the vent holes of the mesh material. So the mesh is slowly removed, and this material that you see right here, the shiny material, is movable, soft, I would call it, but only maybe not even 1/10 or 2/10 of a millimeter typically. So I don't try to remove that. I leave that behind. And below that is extreme density. Now, what I would share with you is when I removed these screws, the same thing was what I found. The screws came out. They weren't loose at all. I had to really unscrew them. And I went ahead, and in the areas where I'm going to plan my implants, I decided to take trephine cores and send them out for histological review. Now, what you're seeing here is 7 millimeter and 10 millimeter markings. So this is 7 millimeters of core. When you take a look at this bone is dense. I couldn't get the core out of the trephine. I had to send the trephine to the histologist just to review and take it out there. So it was very, very dense bone. what we found here is some osteoclastic activity, but predominantly what we found was host bone. 96% of it was living bone, and only 4% of it was bone that was no longer had vital cells. So vital bone, Haversian canals, all of that was found within the core samples. And I thought that that was very, very critical. And that with BMP2 and autogenous chips, that we had 96% autogenous bone in these samples. Bone densities were extremely high, as I mentioned. So in this case, at 8 to 10 months, maybe with autogenous bone chips and BMP, we don't have to wait 8 and 10 months. Today, I'm probably waiting, if I use this concept, 6 months, because with autogenous bones, I'm seeing tremendous density and a shorter healing period. On the opposite side of the same case, smaller horizontal defect, I placed 2 implants and I did conventional GBR, collagen membrane, and fibrin PRGF. So we see 2 different methods of doing things here. One for a smaller size defect, but on the side of the case where we placed our implants, we see tremendous soft tissue healing. We have excellent height of the restoration. You see 2 implants that were placed in the molar and second bicuspid. This was the first bicuspid implant that we maintained. These were the radiographs. And you can see their screw retained restorations. We splinted these because these were the new implants. And this was the previous implant. Now, we didn't get 100% bone fill all the way up to the zero wall deficiency, but we certainly got a very, very nice, maintainable environment with good keratinized tissue. This was the frameworks. This is the BMP2 side, and the opposite side here, this is the side with the GBR. And if we take a look at both sides, BMP2 versus GBR, we see good results, obviously 2 different types of defects, long-term results. What's interesting here is you have recession on the natural tooth, but where we have the implants, we really have maintained no recession on those areas. And when we take a look at this over a longer period of time, day 0, day 60, and then after restoration, we see a very, very nice result. So obviously what we're seeing here is how we go about teaching these skills. These are all the different operatories last year, just to give you guys an idea, because I don't think you see sometimes what's going on in the clinic, Khoury and Robert, because we're so busy. And this is the team to the right. I need an updated picture because we have the perio implant guys that this was a few years ago. We need to add them. But last year, as we all know, we had 40 dentists that came in 2 groups, and it was the biggest and largest course we ever ran. I couldn't thank the people at Metropolitan University and UNEMIS and Jose Marcio and his group, and of course Marcelo Silva, my partner in Atlanta, for doing this with all my friends. And this is their team there at the university, and being able to do it in a brand new clinic with state-of-the-art materials. We're supported at these courses by Salvin Regenerative, the JK Dental Group, and really, really always outstanding for us to be able to do these courses. And I'm hoping, Robert and Howie, that by December we have this coronavirus behind us, and hopefully we'll be back in Brazil to do our 11th year in a row at the university. So with that being said, Mark, maybe we can go to full screen. I'll stop sharing and we can turn on our mics and we can have a little discussion for a few minutes before we end our wonderful session today, because I've enjoyed it immensely.
So Maurice, thank you for that fantastic case. Howie, Robert, for giving different perspectives in terms of what you can do. It's been a pleasure to have you both here as well. I wanted to mention, what kind of timelines do you expect in terms of follow-up if you're choosing GBR versus, for example, a Khoury technique in terms of 1 week, 2 week, and so on follow-ups? Are your timelines any different?
In terms of after the procedure?
Yeah, I mean, we get people asking in terms about potential complications or follow-up.
Okay.
if their timeline would differ with one approach versus the other.
Okay, so typically in my office, when I do a case like that, I like to have my patient back in my office on day number 3, okay, number 7, number 14, and number 21. So on day 3 and 7, what I like to do is to rinse my patients with, ozonated water or a chlorhexidine, something like that. And I like to, do some low laser therapy to help the healing of the tissues. And the same thing I do on day 14 and 21. But now from 14 to 21, I start to remove the sutures of my patients. So this is how I kind of treat them in the very early healing.
Robert, how long do you typically wait for these large 3-dimensional GBR cases before you come back and put in your implants?
So in the big cases, at least 9 months. So as you mentioned that, while Khoury was doing this kind of his presentation of the plates, of tolerable plates, I was doing here like a small lists of aspects related to good and bad, or maybe comparison of the treatments. And the first topic here was the timing. So for sure that if you want to do a GBR procedure, you have to understand that the timing is much higher in terms of waiting. So typically when I start to finish the case, sometimes it's like a 2 years treatment. Whereas Khoury just shown us that less than 1 year, it does everything in terms of the healing process. So for sure, this has some differences in terms of the kind of procedures we're going to do and the perspectives of time, cost, morbidity, and reproducibility as well of either case.
Very, very good. I certainly think that's very pertinent. I think obvious differences, not in my last case because it was in the same flap, but obviously in the cases that you both showed, to harvest autogenous bone, how we did was a secondary surgical site. So you have to look at that as greater morbidity. On the other hand, there's also the type of bone, and which I'm going to mention in a second, ask you both the questions, but the speed in which he can come back and place his implants, shorter healing time. Howie, could you expand on that? How long you wait?
We wait no longer than 4 months. After 4 months, you start, things start to change. So you want to put the implants in optimal at 4 months. I know Khoury does it at 3. I find sometimes the bone's a little bit immature at 3, so I tend to wait 4 months. But yeah, I wait 4 months. I put my implants in. I wait 3 months, and I do my exposure. So by the end of say 7 months of the treatment, because obviously unless there was extraction. So it's 2 months extraction, 4 months bone, 3 months implant, and then I'm moving into a provisional phase in the anterior. So the patient will have something fixed usually 7 months after beginning of bone graft surgery.
Howie, another question for you. In the case you showed, I noticed you had an occlusal lid in order to create the Khoury technique, and I've seen other people that advocate against that. So is there a reason why you would choose one versus not using it?
Good question.
I don't know why anyone would advocate against using it. It really just comes down to how ultimately what we're trying to do is we're trying to create graft stability and space maintenance, and how you achieve it, whether you use it with the vertical with a lid or whether you use a buccal and a palatal wall is immaterial. The periosteum is a membrane, so the periosteum itself will give you that support, and we know that from Khoury's tunnel technique, and where you use just the occlusal and the buccal. So I don't agree with the fact that you shouldn't use an occlusal plate. I don't have a specific rationale when I use it. I think it's the kind of thing when I feel like in that case the type of defect that I had, it worked better to get it with buccal and occlusal rather than buccal and palatal. The palatal wall would have made, if I put a palatal wall in, it would have made it much more difficult for me to get flat closure because I would have then been pushing the palate outwards, whereas I could utilize the softness of the granular autogenous shavings against the periosteum to give me the kind of closure and shape that I needed. So it helped to give me the roundness. When I'm working in a straight line, it's easier to do a buccal and a palatal, but when you're working in a curvature, sometimes a top layer and a buccal layer are easier, and then you can pack against the periosteum. So there's no right or wrong. I don't agree with the fact that you shouldn't. I think it's a case by case. Everything's, I think the one thing that I certainly teach, and Mo, you and I have discussed this at length, is that you cannot be dogmatic about any procedure. You cannot be dogmatic about how you approach any single procedure, because any single procedure is going to differ depending on so many variables. And I think today we've kind of expanded on so many of those variables. So I think that's the key. Don't be dogmatic. Look at each case as an individual case, and whatever works best in that case, we make that decision at the time when we're going to do that. And so that's the way I approach things, and it's certainly what I teach. And I don't advocate being dogmatic, because I think that when you get dogmatic, that's when you make mistakes.
100%. And I want to take this opportunity to say that. First of all, Mark, was a great question, because everybody always asks me. I've shown cases where I put the lid, and I've shown cases where I don't, and I use it as a box, and I place fibrin or collagen over the top. I've seen both work. And then somebody asked a question that just wrote to me, and I thought it was very relevant. They said, wow, those were 3 different case presentations that showed 3 different styles of regenerative therapy, and all 3 therapies worked, which is the whole concept with Howie saying, don't be dogmatic. Have enough skill and education in your toolbox so that in the right situation, you don't only have one weapon. You have multiple ways to address a certain situation. And I see so many people saying, I went to this person's course and they told me that you only do this way. And I went to this person's course and they say this way. And one of the really great things that I like about when we're all together and there's 20 expert faculty at these courses is that with 20 surgeries going on in one day, you'll see all of these different methods going on simultaneously with different proctors. Somebody may have more experience. I may send Howie over to somebody who wants to learn how to harvest and shape the bone plates, because Howie has enormous ability and skill and experience to do it. And if I have somebody who wants to use a GBR method, especially with some of these new membranes and how he tacks and does all that stuff, really, I like to send them over to Robert. And if I have some cases with titanium mesh, I'll usually send them over to Abteam. And since I'm not capable of doing any of these procedures, I just come and watch you all. So that's been great. I've learned so much. Look how good I've become. But what I want to ask is another really good question. Somebody asked, and I'm going to address this individually. Robert, what do you do if you have a wound dehiscence, an exposure of a membrane? And then I'm going to ask Howie, what do you do if you have a wound dehiscence and a plate exposure? Robert, why don't you go first?
Besides crying, after what I do besides crying, okay. Yeah, the problem of exposure is a reality. And sometimes I see some people saying that I don't have them. I don't have those.
I did not do it.
Yeah, I don't know what to say about that. But anyway, it happens. Eventually it happens, and we have to understand the cause of it. So pretty much if it happens in early stages, it has to do probably with the handling of the flap. So it might be that I haven't done the proper, dissection of the flap or the flap management, the incision, stuff like that. So we have to understand that in a positive way, in such a way that if it happens, you learn through it, and the next time you not make the same mistake. But if it happens in an early stage, it's very bad and detrimental for the treatment outcome. So the sooner it happens, the worse. And the position of the exposure as well is important. So if it happens in the middle of the area, and for instance, I'm using like a titanium reinforced membrane, I have a chance of keeping that area safe by using some chlorhexidine gel, something like that, to keep it as safely as possible without plaque accumulation. But if the exposure happens towards, the corners of the membrane, it's always a mess, because, very soon we're going to have penetration of bacteria below the edges of the membrane, and there's nothing you can do about it. So I like to evaluate the timing of the exposure. Okay, the sooner, the worse. The location of the exposure, in the center versus the edges of the exposure. And also if I see any sign of infection going on. Because if you see any pus anywhere, like a drop of pus, you have to remove everything right away and, wait for the next moment to do something there. So maybe I'm going to try to, manage those facts, make it clean as much as I can. And after maybe 6 to 8 weeks, I will probably open the area, remove my membrane, evaluate how the bone healing is going on, probably place like a collagen or PRF membranes on the top of that, maybe a collagen membrane, and try to close with a connective tissue graft. But it's very, very bad when something like that happens, for sure.
I'm glad you said it before Howie starts, because I hear people tell me that they're using membranes where the salesperson, a rep, told them, with this membrane, it doesn't matter if it becomes exposed. With this membrane, it's magic, and you can leave it exposed. Even from the beginning, leave it exposed. It's complete nonsense. It's terrible that there are people out there that are telling doctors to do it. And what's worse is I blame the doctors for listening, that they don't go to people with experience who've done and written in the literature and read and get their own education. Don't get it from the manufacturers. Get it from people who are in the trenches, who have experience. Howie, how about if a plate becomes exposed?
I think it's one of the reasons why I like plates so much is that because it's biological, you've got a lot more maneuverability. I think the same applies for plates as what Rob said. Early and late is definitely, there's a huge difference between the two, and suppuration versus no suppuration is without a doubt. And I think just to quickly go to the suppuration, whether it's early or late, you find too many people going in and giving antibiotics. Let's see how it goes. Let's give antibiotics. Let's see how it goes. And that's really just the wrong way to do it. The minute you see suppuration, I could not agree with Rob more. You enter, you clean. If it's rubbish, you take it out, you start again. And the patients have to understand that right from the beginning. And that's the whole concept of being on a doubles team. Do you know what I mean? They understand from the start that if I go in, if you get this infection, if this happens, this is how I'm going to deal with it. Information versus explanation. Do you know what I'm saying? Such key important factors, because it also takes the stress off you, because if it happens, then you've already explained the potential for this to happen and how you're going to manage it. You're not having sleepless nights. It's just, it happens. This is the reality. But how we manage them, the nice thing about them, if there's no infection, whether they're early or late, often what happens is we take drills, and we usually not tungsten carbides. Either I use a lot of water lace, which is there's no vibration on the bone, which I think is important, or you can use a diamond drill. And we really just cut away that until you get a bleeding surface, and then more often than not, it just granulates closed over the top. Again, it's because of the vascularization of the plate around it. You know what I mean? You can get a small area where you get the dehisce and that'll close up. That's, I think, really one of the really cool things about autogenous blocks is the biologics of it is just so much kinder to the patient. And I think you've got much more maneuverability with that. And I don't think we have to be as careful. And I agree with Rob, when I do GBR, which I do GBR, I've used some of Rob's techniques with great success. You have to be far more watchful of those cases. You have to bring them back far more. You have to really kind of babysit the graft. You know what I mean? You've got to walk that graft through. You want to check and see, because if something goes wrong, it can go wrong big, and it can really be a thing. So that's from my point of view why I tend to lean more towards the biologic way. But everything again. And I think the one thing you said, having more than one arrow in your quiver, one of the key factors is if all you have is a hammer, everything looks like a nail. Develop your techniques, learn different techniques, use the right technique for the right situation. You will be more successful than you will be a failure.
I have a question for all three of you guys, actually. So, as a younger practitioner to people starting off in implant dentistry, and they are seeing these kinds of presentations or they attend courses and they get confused about where to start off in terms of regeneration techniques, do you have any advice on kind of where to start off, or kind of a beginning point for these kinds of people?
Well, I think for us, obviously, DentalXP has been around for a while, and what we try to do is first you expose people to methodologies, because you can't educate them in a 30 or 60-minute video. You expose them, and then they have to go and do something didactic to incorporate the knowledge base. So what I would tell everybody is, these days, you're seeing it right now because of coronavirus, sitting at home, these million dental webinars that you're seeing all are, including this one, for, not that this wasn't amazing, this was. But what happens is these are all hit and misses, throwing spaghetti against the wall to stick. And there is no cohesion, there's no cohesive message. So there's no real practicum. There's no curriculum. So I would suggest first going and take the curriculum. I know Howie offers it at his institute. I know Robert does it at the Implant Perio Group. DentalXP has a online program for, you've taken it. Mark, you're a graduate, an implant fellowship program that we have, that Howie is a very significant part of it, and really submitted a lot of content for. And then then going out and learning the practical portions. And what we try to do is we don't try to say you got to go to DentalXP only to Atlanta. So we went ahead and we said there are guys in the world like Robert, like Howie, that have accredited centers. So when people want to go and learn those practical forms, I say, listen, if you're close to South Africa, go there. If you're closer to Brazil, go there. And I think that's how you have to learn, because if you try to become a social media Facebook dentist, you're going to have some really horrible outcomes. You are going to do some mistakes that could be very dangerous. I hate to say even life-threatening in some cases. So don't learn from just seeing this stuff. This is to expose you. Go, because you mentioned younger dentists earlier in their career, and there are a lot of them out there. Start to look for mentors, start to get exposed, get your didactics down, understand the biology, start to go and take practical courses, whether they be on plastic or on specimens. And only then you go to human courses like the course we've just been talking about. The reason Howie and Robert mentioned how much they love it is because not only do students learn enormous amounts over the shoulder while they're doing the procedures, but believe it or not, even all the proctors are learning an enormous amount. I mean, I can tell you clearly that being around Robert and Howie has only made me a better surgeon. There's no doubt about it. I have no ego when it comes to that. I simply tell you that I don't mind learning from my friends, and the fact that they happen to be superstars, that's just better for me. That's my answer.
If I can add to that, I think one thing's for sure is, Facebook has a place. Facebook is aspirational, and it gives people a little bit of an idea of what's available. And I could not agree with Maurice more. And the one thing that young dentists have to remember is that we didn't get here overnight. I've been doing this for more than 25 years. And it has taken me a long, long time. I think the great thing about modern day education is the internet really allows you to fast forward the pace, but it doesn't mean you can learn it in a day, and it doesn't mean you can learn it in a week. And there are small steps. You know what I mean? You can eat the elephant, but you have to eat it slowly, one bite at a time. Learn how to raise your flaps. Learn how to do your flap advancement with smaller cases, and you slowly develop your bricks until you have a wall. Well, that's maybe a bad analogy, Mo. Until you basically built, your foundations. That's maybe a better way to look at it. You built the foundations that allow you to do the kind of work that we're doing. But don't rush. Just slowly, just fine. And I think, Mo, one of the things you said was so key is mentors. Mentors, go and learn from people, and more importantly, don't get stuck in dogma with one person that says this is the only way.
The worst.
Because when that happens, my mind shuts down and I walk away, because I know if that's what they are teaching and that's all they know, then that's not where I want to learn, because I know. I mean, Mo, how many techniques have you developed over the years? Tons of them.
So many.
I've done one or two. Rob, yourself as well. But the fact of the matter is that it doesn't make, and I think this is the key. There are so many practitioners out there who develop a technique, and everything becomes about that technique, where they use that technique for every single situation, and that is dangerous. We need to learn multiple techniques. We need to have multiple mentors. We need to learn from different skills, because each person has a different skill set. I have a different skill set to Rob, to Maurice, we all have strengths and weaknesses in different places. And it's important to be able to take the strengths of each mentor that you get, see the weaknesses for what they are in the mentors that you have. And hopefully you have a mentor who doesn't have an ego, that's not scared to show you the failure and to show you where the problems, because that's actually where you learn more. And I think, Maurice, that's something we do, Rob, but to see the complications and to see the failure, that's key. And I think that's to any young person out there, that's the message I would give.
Yeah, great.
Yeah, I completely agree with you guys on that. And basically, there's no shortcuts, when you're talking about this kind of procedures. It's like they say, it takes 7 years to become 7. You cannot become 7 only 1 year after you were born. It takes time, to develop the skills and everything you have to do. And take your time, as Khoury said, to start growing in the process in a very easy way, step by step. And that is important, because sometimes when I give courses, and I'm pretty sure it happens to all of you, and I show those like bigger cases, and all of a sudden in my email and WhatsApp, I get, messages from people that were in my course and said, now how can I solve this problem? Because they did the case without being prepared. So I like to say that they had to do like 50 horizontal reaugmentations with resorbable membranes or LPRF, something like that, before they start to attack, the vertical cases. And only step by step, they will learn how to manage the soft tissues and the tricks related to the tacking of the membranes and the stabilization of the blocks, and how to close it in a tension-free way. And it takes time, so you have to be patient, to learn step by step until you are able to do the things that Khoury, Maurice, and maybe I can do. And having multiple, mentors is very good. I could not skip the opportunity to say that, in my early days of dentistry, I already had Maurice like a mentor, even though he didn't know me. And a lot of things that I do today actually came from DentalXP. I learned it from that, and I'm starting to show people now in the same way.
Well, I think this is a good time to wrap things up, guys. I can't thank you enough. Not just the friends you are and the talents and the educators you all are, but the grace and how willing you are to share. You're like that as friends. You're like that as educators. You're like that as family members. And the world's a better place because people like you are around and exist. And I just wanted to thank you for taking the time. It was supposed to be 90 minutes, so it went a little over. But I think it was worthwhile. Mark, can't thank you enough putting this stuff together with me. We'll probably try to do something again, maybe by the end of the month, if Mark is willing. And of course, guys, look forward to seeing you again at a time that we can share a drink together, and hopefully that'll happen before Santos in December. And I know Howie's dark there behind you, so I know it's already time for a drink. You know, but as Jimmy Buffett said,
we don't have alcohol in South Africa. We're not allowed.
Too bad, because if you were here, you'd be sharing all those bottles up there with me. But I do want to tell you that we hope.
Can't wait to get back.
We pray, we hope that we're going to be together soon, and that all of this will be behind us. Please stay safe, stay close to your families, and please stay in touch with us. Mark, really, again, fantastic job. Thanks to Canadian Implant Dental Network, DentalXP, Facebook group, to the Implant Perio Group Brazil, and to Implant Aesthetic Academy South Africa. 3 continents, I think, were really, really well represented. They should all be proud of you guys. God bless, guys.
Thank you. Thanks, guys.
Take care.
Thanks, Mo. Thanks, Mark.
Thank you so much.
Cheers.
Thank you so much.